Good afternoon, everyone. My topic today is titled Edematous Masquerade. It's a rare presentation of papilledema in a case of acute myeloid leukemia. So to start with, I can say that acute myeloid leukemia can either present with ocular features or can be associated with secondary ocular involvement. The prevalence of ophthalmic features has been estimated over a wide range of 9 to 90%, and the ocular features could be direct, they could be secondary, or they could be neuro-ophthalmological. And neuro-ophthalmological signs could include optic nerve infiltration, cranial nerve palsies, and papilledema. So today I'll be presenting an unusual case of papilledema along with LR palsy as the presenting features in a child with acute myeloid leukemia. So a 12-year-old boy was brought to us to the pediatric emergency with diplopia in the right gaze since 10 days, headache and fever since 3 days, and severe bouts of vomiting since a day. So he also had a past history of right retroauricular pain and mucopurulent ear discharge, for which he was locally treated. So on ocular examination, visual acuity was 6.6, lid and adnexa and anterior segment on slit lamp examination was within normal limits, and color vision was normal. So the child had right eye esotropia, approximately 30-degree deviation, and abduction limitation of the right eye, which was suggestive of LR palsy. Right, so you can see that. So on fundus examination, there were features suggestive of severe papilledema. Simultaneous ENT examination was done, and the patient was found to have CSOM along with left mastoid tenderness. CSF pressure, because there was papilledema, they wanted to do LP, and CSF pressure was raised, 57 centimeters of water. And then on systemic examination, the total count was found to be 7,000, and platelet count was 51. A peripheral smear was done where they found out there was 33% of blast cells, a consecutive flow cytometry was done, and AML was confirmed. So MRI was planned, and that showed a prominent sigmoid transverse sinus, right sigmoid compressed right sigmoid sinus, a prominent transverse sinus, and a very mild enhancement of the subarachnoid space, along with bilateral otomastoiditis. And then further MR venogram was done, and that turned out to be normal. So the most striking feature of this case was sixth nerve palsy, and sixth nerve palsy can be true or false. So whenever it is because of raised intracranial pressure, it causes false localizing palsy, and that is basically because of the its extended route to the orbit, and because of its 90-degree ascent at the clivus. So papilledema per se and isolated sixth nerve palsy, few cases have been reported, but a combination of both has been very rarely reported in a case of AML. So whenever you have LR palsy because of raised intracranial pressure and papilledema, all the causes of subarachnoid space must be ruled out, which includes hemorrhage as the most common cause, meningeal, parameningeal infections, infiltrative conditions like lymphomas, leukemias, carcinomas, and inflammatory as well, like sarcoidosis. In my case, the differentials can be considered transverse sinus thrombosis, intracranial space-occupying lesions, neurosurgical trauma, meningitis, and pseudotumor cerebri as well. So since this child had bilateral otomastoiditis, which is again a very striking feature, that could also be a cause of raised intracranial pressure, because that could lead to transverse sinus thrombosis, and that could lead to raised ICP and then LR palsy. But then again, MR venogram was done, and that was clear. So basically, the cause was AML. So to conclude, I can say that acute myeloid leukemia can present with papilledema and sixth nerve palsy, and can be mistaken for various other causes of raised intracranial pressure. The physician may not always be able to appreciate the ocular manifestations of leukemia, since majority of the subjects remain asymptomatic, and an early and prompt recognition of ocular manifestation is considered very crucial, as the eye involvement signifies poor prognosis, and hence the role of an ophthalmologist is helpful in the course of diagnosis. Thank you so much.